There are other people who think that medication is everything, it's the magic bullet, and rely upon this solely as a means of recovery. They don't take themselves to therapy. I can't tell you how many emails I get from people asking about this medication, that medication, does it work, does it not work, what do I recommend? And then I'll email them back and say, well, are you in any kind of, cognitive behavioral treatment? And they'll say, no. And I say, well, you're only getting half the treatment. Why are you doing this? This is a big mistake. And I try to encourage people to get themselves into therapy. But, some people think that this, they have this undying faith in medication that will cure everything perfectly. In fact, they kind of see it like this, in a way. This is the pharmacologist of Oz. So the scarecrow takes Ritalin, the Kid Windman takes L-Nova, and the Cowardly Lion takes Xanax, I'm going to steal this glass of water here. Okay. So this is how some people at the other end of the spectrum see that. But I think that either end of the spectrum of either being totally against medications or only relying on medications, I think is a big mistake. I think you really have to watch out for that. The people who only want medications tend to be very passive in their approach to getting help. They sort of see it more like a trip to the dentist, where you just sit there and somebody makes you better and you just sort of don't have to do anything. You just have to show up, essentially. And that's what people would like getting well to be like, that I don't actually have to do anything. I just, take my pill and that'll make me better. Now, occasionally, yeah, you will see somebody who gets a really, really high level of improvement on medication. That's terrific. We all hope that people who take medications get that, but it doesn't turn out to be that way. I'll talk more about that in a little bit, actually. Now, going back to the people who are against medication, these are usually it's based on one of a number of common misconceptions about medication. One is that they're dangerous, it can cause dangerous and irreversible side effects. Second is that these bad side effects may not show up for many years, and in OCD that's a real big one. How do I know that in 30 years I won't find out that I have cancer or I'm going to grow another head or something like that? The third idea is that they can change your personality. Like, I don't want to be changed. I don't want to be different than I am. So I don't want to take medication that will change me. I'll be somebody else. I'll be unrecognizable. Another one is that they will turn you into a walking zombie. I hear this phrase all the time. I don't want to be a zombie, doc. I don't want to take medication. I don't want to walk around the fog all day. And I agree. I'll get back to that in a second when I talk about some answers to these things. Another one is that the person says, I don't want to be forced into a life of addiction. I don't want to become an addict. I don't want to be dependent on medication because that'll mean I'm weak and I can't do it myself. And that sort of plugs into the last one on here, which is that any improvements you get will be worthless because you didn't do it on your own. For instance, well, I don't want to think that I got better just because I took a pill, because I took medication. It won't be meaningful. It doesn't mean anything. Now let me answer some of these things, okay? First of all, with only one exception, the medications currently used to treat OCD have been in use, not just here. Most of these medications that we now use today were in use in Europe long before they ever came to the United States. A lot of them were used in the 1970s, actually, before they ever made it here. So a lot of these drugs have been around probably for about 3 decades or so. I tell my patients, I said, if you could only take pills that had proven themselves to not cause long-term side effects, you could only take drugs developed before 1975 or something. That wouldn't leave you too many effective medications to treat almost anything. So we have to be very careful. Not to say that all drugs are perfect, but sometimes, occasionally a drug, like Vioxx or things won't turn up that, yes, does have problems. In fact, I took Celebrex for a while myself, and luckily it didn't work that well for me, so I got off it because I suffer from arthritis. But I did not, so yeah, I would agree. But as you'll hear me say again later on, everything in life entails a certain degree of risk. That's it, so if you want to, well, I'll get back to that anyway. So anyway, I would say that SSRIs as a group of drugs have been around for a long time. They've proven themselves. They're safe. They're effective. Again, they're not perfect. They don't work for everybody, but they're the best thing we have. Maybe the next generation of medications will surpass them, and we'll have some even better tools than we have now. Next is, medication cannot change your personality. They can eliminate or reduce brain problems that are keeping you from being who you really are, but it won't turn you into somebody unrecognizable. Like you had a personality transplant or something. Here's my little, I don't know if you can read this. It shows, for those who can't see too well from where they are, there's a king sitting on his throne in a room full of skulls, and he says, my antidepressant made me do it. So, anyway, that's what some people. Now, it's true that some people have been let me go back here. You know, you talk about being a walking zombie. It's true, some people have been over-medicated. There are bad psychiatrists and bad MDs out there who are actually even dangerous. I'm very picky about who I refer my patients to. Very few MDs that I like or trust, basically. I've only got maybe about half a dozen people out there that I'm even willing to send my patients to. Because a lot of the others are really either don't know what they're doing or they're even dangerous in some ways. You know, so it's a buyer's market, basically, unfortunately. You should always go by, you know, good word of mouth from people. But people who are properly medicated should be able to function normally. In fact, I tell patients, so the idea of proper medication is that you should be able to take your medication and still function the way you always function. It shouldn't suddenly place limitations on your life, and there are things that you cannot do anymore, or that you can't get out of bed, or you're dizzy, or you're gaining, you know, 50 pounds or something like that. I think that's, you know, terrible occurrences and should definitely not be allowed to occur. And I think that's why people need to be closely monitored on medication, so that if somebody is having, you know, an undue reaction, that it's spotted right away and picked up and dealt with. So this is what you see in good medication treatment, when you have a good psychiatrist who really knows what they're doing and cares about their job enough. And there's no excuse for medication not being well managed, because, you know, we have the know-how, basically. It's just a matter of applying it. So now, as far as addiction, medications used to treat OCD, with the exception of tranquilizers, which I'm not a big fan of, are not addictive. It would be like saying that insulin or asthma medications are addictive. You know, people do not get cravings for antidepressants or antipsychotics. Now, as for tranquilizers, they were never intended for long-term use. So, you know, my patients who are on them generally do not like them to stay on for long periods of time, but, you know, only the occasional exception of somebody who really has shown that it really makes a tremendous difference to them, and you know, they're not having undue side effects from it. But, you know, there are a lot of physicians who keep people on tranquilizers for decades, and I think it's just unconscionable. I do not like it. And, you know, I think those who abuse tranquilizers tend to be those who have not received proper therapy and who are looking for a quick fix anyway. On the other hand, some people are convinced that that's all that will help them, and I sympathize with them. But these things, actually, you can get more long-term problems with the use of tranquilizers. In addition to addiction, sometimes depression or memory problems can result from taking these things for very long term. It's not a good thing. Now, the idea that recovery, resulting in part, at least, from medications, is not real recovery is hogwash. Okay? OCD has a biological core that in many cases must be treated if you're going to be successful in recovering from this. And I think that to say that, oh, it's not a real recovery if the medication helps me, is being sort of like a compulsively scrupulous way of looking at things. And some of my scrupulosity patients actually do have problems with this issue. I mean, you might as well say the same thing about asthma. You know, if I can't manage my asthma attacks without medication, then it doesn't mean anything. You know, it's not valid, or I'm not virtuous enough. You know, it's not a moral issue here. We're talking about getting recovered. You know, forget what it looks like. You know, I mean, yeah, you want to tough it out, fine. You want to get your stitches without local anesthesia, be my guest. But you know, I can't see the point to it. And quite frankly, a lot of people do much better on medication than without, and it makes the therapy go quicker, and it makes the recovery more durable, basically. So I think that, you know, the way OCD devastates people's lives, that the number one priority is to recover and not just stick to some rigid principle that will keep you from being free of the effects of the disorder. I myself, I know we're going to take a break in a moment, so I'm going to find a place to stop here, but let me see. Actually, we're getting close, so. Okay, Alan? Okay. I take a very pragmatic approach to treating OCD rather than saying that things simply can or can't be used. I think you use what tools you have in a practical manner. I say if it works, do it, you know. Unfortunately, there's a lot of things that don't work. But I'm very much against having a doctrine that tells you that you can only limit yourself to certain kinds of treatment. I think you have to, you know, again, be open to things and you know, and go on the basis of what works and what the evidence tells us. And the research actually tells us that medication and behavioral therapy together work better than either one alone. That's what the research says. You don't have to like it, but that's what it says. You know, as one of my old professors used to say, I'll believe anything you say, just show me your data. That's all. So if you can show me data that, you know, one or the other is better than both together, I'll believe you. But until we get data to the contrary, that's the way things are. Now, I know some people who have gotten well using only one and not the other, but again, they don't represent the majority. That's what you got to keep remembering out there. I have nothing against people trying cognitive behavioral therapy alone. many people come in and say, look, I don't want to jump to medications right away. I want to try CBT first, and then, you know, if we need medications, we'll think about it. And I say, fine, you know, no problem. Or even if you're against medications, let's give it our best shot and see what happens. If you can do without, great. But if you can't, I hope you'll be wise enough to at least admit that, you know, that you can see that you're not going to do it without it, and that's going to be, you know, a real hard job without. So, you know, a lot of times people are very anxious about using psychoactive drugs. So, but again, that's not a problem. I'm not against that. I'm always willing to give somebody a try. But I always reserve the right to tell them if I think that, you know, maybe it was not the right path for them. Again, as I said before, I don't think that using meds alone is a good idea. The thing is, medication cannot teach you to think differently about learning to confront anxiety. It can't give you a different outlook on things. It can't make you feel more effective in managing yourself or controlling your own behavior. So I think that, you know, if you stop taking it and you go back to square one, then, you know, I think this is telling you something. I think you know, then this is what typically happens. Being on medication alone, even if you're getting a fairly good result, makes you vulnerable. You need other tools. In fact, I see medication. Okay. I say medication should be regarded as a tool to help you to do therapy, basically, and that's really the key. That's how I view medication. It is not a treatment in itself. It's only part of the treatment, basically. So it should not be seen as a standalone kind of approach. It bothers me that there are some therapists who are also against the use of medication, never mind their patients, and who actively discourage patients from seeking this. And on the other hand, there's also physicians who don't refer people for CBT. I can't tell you how many people have been seeing psychiatrists for years, and they say, well, did your psychiatrist ever mention the possibility of CBT? And I'll say, well, no, he never mentioned it. I looked it up on the internet. I found it myself, and I asked my psychiatrist, would it be okay if I tried this? And my psychiatrist said, well, you know, go ahead if you think it'll work. And I'm saying, geez, you know, we psychologists know about medication. Why don't the MDs know about therapy? You know, it's astounding. It just shows you what a gap there is in medical training that these folks really don't know about these things or aren't aware of them. In fact, I actually had I just got to tell you this quick little story. I had a patient of mine who was having thoughts about stabbing his wife, obsessive thoughts. And so we had done some behavioral therapy, which involved, you know, handling knives around his wife and you know, exposing him to the thought that he really was going to stab her. We did some behavioral therapy for that. So he went to his psychiatrist who said, how are you doing? The guy says, oh, I'm feeling a lot better now. I'm really doing a lot better. I'm a lot less anxious. So he said, well, what is you know, Dr. Penzel doing with you? So he started to relate some of the things, and he said, that sounds rather extreme to me. And I'm really quoting, it's exactly what he said, it sounds rather extreme to me. He said, I have my doubts about whether you should be doing this or not. So then, of course, the patient immediately started obsessing, oh, gee, maybe I'm in the wrong treatment, you know, he got his sort of OCD machine working, and he started to become doubtful about, you know, what was really helping him in a good treatment. But this is typical kind of physician ignorance you run into out there. And not all physicians are like this. Some very sharp physicians who know about these things. But these guys just don't stay current. They don't read up on anything. They don't read their own journals. They're not aware of what's going on out there. I read the medical journals. I like to know all about medication, things for my patients. These guys can't be bothered. So, in any case, I guess we're at a point where, we can stop right now. So I just, 15 minutes? Okay, let's pick up from where we left off.
I actually found one. Thank you so much.
Okay, if I can have everybody's attention. Okay. We're going to talk about the fifth thing on our list of our potholes on the road to recovery. The fifth thing was getting the right treatment, but one that's too weak and ineffective to do any good. Which usually it means that it was not done by a specialist with specific training. I think it is possible to be in the right therapy and to be getting the right therapy, but to not get any real benefit from it. And I think that that's you know, very clear. I like to tell my patients that I consider myself an industrial strength therapist. And I think that therapy that's timid and that fears to make the people who engage in it face the discomfort in any way is a therapy that will not work. Okay, I think therapy, when you get right down to it, I think there's no way to overcome the things you fear without confronting those fears. And that means experiencing hard work and discomfort, which, you know, we would all like to get better without, but there's no way around it. Okay, now the problem with some therapies is that some therapists are so overly cautious about making their patient anxious and almost feel guilty about making them uncomfortable that they don't give them therapy assignments that are challenging enough to have an impact on their symptoms. I've met people who said, oh yeah, I was in cognitive behavioral therapy, and I said, well, tell me what you did. And they talk about sort of this weak little exercise. And say, how would that help? I can't even imagine that it would really get at the symptoms. So they were in the right therapy, it just wasn't effective enough. And you know, not only do they not get challenging assignments, but sometimes the therapists, if they're uncomfortable about treating particular symptoms, they sort of skirt around them and never really get to the heart of the person's OCD. I think if you don't gain enough control over your symptoms in treatment, you're going to have a rebound when you get out of there. So this is what we want to avoid. I think when you leave therapy, you should be left in a state that you can handle the unexpected. In fact, I always tell my patients with OCD, always expect the unexpected, you know, because you never know what you're going to hear or run into, or what situation you're going to find yourself in out there. And believe me, almost anything can happen. So don't get me wrong, I'm not talking about, you know, like really rocking and socking people with massive amounts of anxiety, or saying that you have to face everything you fear all at once. But I think to recover, it's not necessary for you to experience anxiety at those, you know, massive levels. But you know, the goal is not to scare patients away from treatment. I wouldn't have any patients left if I did that. But proper behavioral therapy is done in a gradual, step-by-step way, and goes at whatever pace the patient can manage at any given time. And it takes patients to levels that will get them well and enable them to stay well. If you don't go, you know, right to the heart of what you fear and really do a thorough job of it, you're going to be back in treatment again in no time at all. Now, another problem commonly seen in behavioral therapies that are the right therapy but don't work very well are where the therapist gets confused in terms of the differences between obsessions and mental compulsions. Now, we know in the case of obsessions that the goal is to confront them. In other words, you expose yourself to the obsessive thought in many ways. You do it through audio tapes, through you know, watching films that might bring it on, reading books, going to websites, putting yourself in situations out there in the real world that are going to, you know, make you have your doubts and cause uncertainty. And then, you know, so the goal is confrontation here. And with compulsions, of course, the goal is to resist doing anything compulsive to relieve your anxiety. People with OCD don't stay with what they fear long enough to find out the truth of what really happens. Okay? And I think that a lot of therapists don't do a proper behavioral analysis. They confuse obsessions with compulsions, or compulsions, you know, with obsessions, and they often give the wrong homework, you know, the wrong kind of homework for the wrong symptom. Now, part of this I blame on this notion out there. Somebody actually asked me a question about this earlier. This mistaken notion that quite a few people are what we call purely obsessional. I think the term was pure O has come in. I really don't like that term. In my own practice, only a very small percentage of OCD sufferers I have seen over here, and I mean a very small percentage, could be said to have no significant compulsions. Although many of them had compulsions in the past, and just sort of, they fell by the wayside. They couldn't even remember why they did them anymore, but they still had the obsession. But that doesn't mean they were purely obsessive. I think that a lot of patients who say they are purely obsessive come to me. Now, some therapists will just take that at face value. I don't. I look a lot further. I think that if you ask people very closely, you'll find that it sort of goes against intuition that somebody would get these kinds of thoughts and not act on them in some way. You know, it's that they're just going to sit there and take it. Everybody responds to you know, these kind of outlandish thoughts. So in any case, I don't believe that there's really that much in terms of pure obsessionality around out there. There's a few people, I wouldn't deny it, but I think that a lot of people don't get treated properly because people just accept that notion of face value. So I think the moral of the story here is that therapy is only good as the therapist administering it. I like to say, always make sure your therapist has had proper training and supervision. Don't be shy about asking them about this either. Now, as I mentioned, medication is also part of comprehensive treatment, and so you can be, you know, getting drug treatment, but again, not be in the right drug treatment, basically. To paraphrase what I just said, you know, a medication is only good as the physician who prescribes it, basically. Medication is just medication. I've seen a lot of people, you know, needlessly give up on drugs that could have helped them. When discussing previous treatment histories with people, they'll always tell me that oh, my physician's in the past tried this drug and that drug, and that it didn't work. And then sometimes I think these things get taken at face value, but I think there are certain things that should be checked first before assuming that what you're taking or what you have taken in the past will not work for you. Okay, these are why medications may appear to not be working. One is the drug was not taken for a long enough period of time. I've seen people who, switch drugs almost every other week. I call it drug of the month club. People are constantly switching around. They never stay on anything long enough to find out if it really works. Secondly, the maximum dose reached was not large enough. Now, some physicians, I've actually met physicians who aren't even comfortable prescribing the maximum allowable dosages of drugs. And I call this the practice of defensive medicine, basically. The person who are worried about getting sued and getting the patient well. And I'll even say, it says right here in the PDR that you can give up to this amount. They say, well, I don't give amounts higher than, such and such, whatever it is. They say, if you want that, go to see another doctor. And I've had patients told that. They, if you want that, go to another physician. So, and they do, basically, and they should. Now, actually, I also know of a few physicians who are willing to prescribe higher than the maximum dosage. Some people actually need larger doses. I call them high-dose people, basically. I've had people who didn't even show any signs of improvement until they got above the recommended dosage, and it worked for them. And they, as long as the person's not having side effects, I think, and is tolerating it okay, there's a certain point you can go up to. I'm not talking about, like really massive, unsafe amounts, but it is possible to go a bit past the maximum and it not be that hazardous. They've done studies in Europe that actually show that it is safe to do and it has been done. A lot of these levels are just sort of arbitrarily set. Okay, third one is the medication was not taken as directed. There are studies that show that among antibiotic users that about 50% of people never finish their prescription. And I have a feeling that with psychoactive drugs that also a lot of people either don't take them regularly or they skip days or weeks or doses. And it's unbelievable the things that people do sometimes in terms of not taking their medication properly. Next is the dose was built up too quickly. Again, some physicians will take somebody into the maximum dose like in a week or 10 days, and in a lot of people this will bring on side effects they probably wouldn't even have gotten if they just done it slowly over a period of time. So, and of course that causes people to abandon the drug, and the physicians say, well, I can't take it because I can't take the side effects. I say, well, if you can build up more slowly, maybe you wouldn't have these side effects to begin with. So I think that's another issue. Another one is that the initial dose was too high, the starting dose. Some physicians are like really gung-ho and they want to see the patient improve, but some of these things your body needs to build up a sort of an acclimatization to, basically. If you give somebody too much at once, they just can't handle it. So, there are also people I call low-dose people. People who can't tolerate the normal doses. I've had people actually improve on as little as 1 milligram of Prozac. And you wouldn't think that would work, but it did. And actually there are physicians, not physicians, pharmacists rather out there who are called compounding pharmacists who can reduce any drug to a liquid and enable you to take doses as small as a milligram. They can even flavor them actually too. And you can look them up. They have a website. It's like an International Association of Compounding Pharmacists. To see if people can't swallow pills or capsules or for people who need much tinier doses. In fact, my own son has been on Prozac now for about 10 years. And when he first started, a lot of autistic people can be exquisitely drug sensitive. He was so sensitive that he could only tolerate a half a milligram of Prozac every other day to start with. He was what I would call a low-dose person. And he takes liquid Prozac diluted with sugar syrup. And we measure it out like in drops. That's how little he takes. But it works for him. It really had a noticeable improvement. So that's a good case in point. And lastly, drug augmentation was not tried. Sometimes some people's symptoms involve more than one brain chemical, and one drug won't cover all the bases. That's why sometimes antipsychotics are prescribed along with SSRIs, because the problem is not just the problem of serotonin, which is what SSRIs work on, but also a problem of the brain chemical dopamine. Sometimes you see that in body dysmorphic disorder especially, but where people usually have very strongly held thoughts, where they start to be, very convincing to the person. Sometimes a small amount of an antipsychotic drug will help. Now people get scared off by the name antipsychotic, and I don't want to be on that. Maybe it means I'm schizophrenic, and things like that. But they do have many other uses, and it seems like some people's serotonin problems may be secondary to problems with dopamine, because when you give both drugs together, you see a vastly greater improvement than when you're just giving an SSRI alone. So, in any case, this used to be, giving more than one drug at a time used to be called polypharmacy. And the word out on the street was that it's dangerous, and you can't do it, and you shouldn't do it. But quite frankly, it's used quite widely by physicians in the know, and when it's done properly, you can get some really excellent results. Okay, let's move along here. I'm going to keep moving. Okay, the sixth one on our list was a lack of basic acceptances on the part of the sufferer. Now, sometimes you can have the best therapist, you can have the right medication, you can have the right kind of therapy, and plenty of support from people in your life, and it may still not be enough because a person's philosophy is what's at fault here. There are problems with the way the person views the world and the way they view themselves and the way they view treatment. Everyone has a personal philosophy, whether they recognize it or not. Some people's philosophies are helpful and logical and enable them to face life's difficulties, but some people's are not so helpful and logical. Some have philosophies that are irrational and illogical and very extreme, that do not equip them to face life in the real world. We acquire these views from our parents, from people we encounter, some we create based on our own experiences in life. There's a lot of ways that people get these ideas. But some of the ideas that are rather unhelpful to people in treatment who are trying to recover from OCD would include non-acceptance of some of the following. Okay. These are the things that you have to accept in order to succeed in treatment. One is that you have OCD. That's pretty basic, although believe it or not, there's some people who do not accept that they have OCD. Second, that you will never perfect your OCD. That's like the person who says, there must be a way that I can do all these compulsions and deal with all my anxieties compulsively and still function like everybody else. That's like the alcoholic who thinks they can drink a quart of vodka every day and function like everybody else. It ain't going to happen. Okay, it just won't. It'll eat up your life, basically. It eventually will take over. Thirdly, you cannot keep on compulsively protecting yourself and others and still recover. That's another thing you have to accept. Again, it has to do, again, with perfecting your symptoms. You're never all going to get them buttoned down. You're never going to protect everybody and get all the uncertainty out of your life and everything else and still recover. That's not compatible. Okay? And it says that there are tasks that you have to accomplish on your own in order to recover. In other words, things that only you can face and do and that no one can do for you. And no one should do for you either. Now, when you don't accept ideas like this, they cause paradoxes, which means that people produce the opposite of what they set out to achieve. Again, as I said, people fundamentally do not accept some of these ideas, so it brings about the opposite. Like, for instance, not accepting that you have OCD, the idea that, well, if I don't acknowledge a problem, I don't really have it. Well, that doesn't turn out to be true. This is not a very effective way of dealing with problems. Maybe they're hoping they'll wake up one morning and find that it's gone, but they won't, It's like a lot of people who say, oh, it's just some bad habits, or I could stop doing it if I really wanted to, or I don't know what all the fuss is about, this really doesn't affect my life that much, and so forth. But again, as I like to tell people, you cannot change what you cannot accept, basically. So this is a very basic kind of acceptance, I think, that you have to achieve. List here, okay? Again, if dealing with some of the other things, if you keep on trying to find more efficient ways to do compulsions while somehow living a normal life, you will not succeed. Again, I cannot stress this enough. It will spill over into other areas of your life. I like to tell my patients that OCD will take away everything that is important to you if you allow it to, and it will try to do just that. As far as the third concept on there about protecting yourself and everybody else, people with OCD are not risk takers, as I'm sure you know, and tend to try to play it safe in many areas of their lives. But by trying to perfect, getting rid of uncertainty and to make everything certain and to eliminate all risk, they actually make their lives riskier. They tend to destroy their everyday lives. What I like to say is that when you attempt to eliminate risk from your life, you eliminate along with it your ability to function. Or there was always a quote I like from Malcolm Forbes, the financier, who said that he was a professional risk taker, and he said just getting out of bed in the morning is taking a risk. And I agree with that. Now, as far as the going back to our list, let's see. Okay, accepting the task that you actually have to accomplish. There's a lot of people who look at treatment and say, oh, I can't do it, it's too hard. It's too hard, I can't do it, don't expect me to do all that. And I would never try to characterize recovery or attempts to recover as being easy, okay? It's not easy, and patients will never hear me say that word, okay? But as I like to tell my patients, I say, it's not too hard, it's just hard. That's all. If it was too hard, nobody could do it. And quite frankly, people are recovering all the time, and I've seen them do it. I mean, facing your worst doubts and fears may never be easy, but I always tell my patients, say, what have you got to lose? I mean, if you think therapy is hard, try living